Hello, sir. This talk is regarding how to evaluate a sleep study report. So, it's a short talk of 15 minutes. So, I'll just share my PowerPoint presentation. So, we will. So, sir, this is a quick review of what to look in a sleep study report. So, the sleep is a music, and here we will study the Sare Gamma of sleep. So this is just a mnemonic of a little bit of theory. What is this sleep study report done for obstructive sleep apnea patient? So what to look in it? So SA is sleep architecture. So normally human being lives in three stages. Either he is awake, or he is in non-REM sleep, or in REM sleep. So there is smooth transition from one stage to another stage, and there is no problem in transition. So when we go to sleep, see the amount of time to taken for go to sleep is called a sleep latency. So it is about 5 minutes to 30 minutes. So even if you slept within seconds, that is also abnormal, which can be because of sleep deprivation or some medication as well. But if this latency is increased, that is also abnormal. So once you slept, first we go to stage one of non-REM sleep, and after that stage two and stage three. So we can find in which stage the individual is by EEG. Like in stage one, there'll be alpha waves. In stage two, there'll be beta waves and K spindle. And stage three, which is deep sleep, there are theta waves. After stage three, an individual goes into REM sleep. In REM sleep, it's called as rapid eye movement sleep. The all muscles of body are almost paralyzed except heart, diaphragm, and extraocular movement, and brain is active. It utilizes same amount of oxygen as in awake stage. So this is dreaming time of sleep. We dream in this stage, so all muscles are paralyzed as a protective mechanism, because if these are not paralyzed, we might act out of our dream, and that is REM sleep disorder, and most commonly seen in Parkinsonism patient, where there is failure to relax the muscles. And suppose in sleep study, uh, the normal individual spends 70 to 80% of his sleep time in non-REM sleep, remaining 20% in REM sleep. Neonate spend 50% in non-REM and 50% in REM. As age advances, non-REM sleep goes down, REM sleep goes down, and uh, suppose in sleep study, what happens as we go deeper in the sleep from stage 2 to stage 3, muscles relax and the obstruction increases. So when the obstruction increases, when there is increased obstruction, the arousal occur and patient again goes in stage 1. Again he falls asleep and goes deeper stage in stage 3 or REM, and there is sleep obstruction or apnea or hypoapnea, and person wakes up and again he goes in stage 1. So in obstructive sleep apnea patient, uh, there are lesser deeper sleep level and even REM. So if REM percentage is less, that means that study has under evaluated apnea or hypoapnea. because if patient had achieved the same amount of REM sleep, there would have been more apneas and hypoapnea in REM because muscles are almost paralyzed. So then in sleep study we see total sleep time, means when the technician says light out and go to sleep, and when wake up, that is total recorded time. And in EEG we see total sleep time, and it is, the percentage is called as sleep efficiency. This percentage is called as sleep efficiency. So when we go to sleep, the REM sleep starts almost after 90 to 110 minutes. So if REM latency is decreased, that is not that can suggest patient having narcolepsy, although it is not pathognomic of this feature, but then it can suggest a patient having narcolepsy, because and narcolepsy patient will have cataplexy, that is sudden loss of tone of all limbs in emotional time in daytime. So I go to another alphabet of Saregama, that is respiratory event. So respiratory events may, first we have to know what is apnea. Apnea is decreased air nasal flow more than 90% for more than 10 seconds. That is apnea. And hypoapnea is reduction of airflow, more than 30% reduction in airflow for more than 10 seconds, associated with either fall, either arousal and or fall in oxygen saturation of 3%. And that is definition of hypopnea. There is one more definition hypopnea, when the oxygen desaturation is 4%. So we have to just make sure what definition of hypopnea the study has taken. And third thing we should know is what is RERA. It is respiratory event related arousal. So when there is no apnea, no hypoapnea, but then there is respiratory effort, that we can see in flattening of nasal curve, nasal flow curve, and associated with that, if there is arousal which doesn't fall in definition of either apnea or hypopnea, it's called as respiratory event related arousal. So number of apneas and hypoapneas occurred every hour of sleep is called as apnea hypopnea index. So if we include RERAs in this, it's called as respiratory disturbance index, that is RDI. And central apnea is when there is cessation of breathing, but then no effort seen on chest and abdominal belt. It's called central apnea. So when there is apnea and hypopnea, we have to also see whether there is difference in supine and non-supine position. Suppose few patient sleep in lateral position and then he has zero apneas or hypoapnea, straight away we can suggest him to lie on lateral position, and that will be therapeutic for him. So the grading of apnea and hypoapnea in adult is like, when there is 5 to 15, it's called as mild. 15 to 30, it's moderate. And more than 30 is severe apnea, hypoapnea. And less than 5 is normal. And in children, less than 1 is normal. 1 to 5 is mild apnea, hypoapnea. And 5 to 10 is moderate. And more than 10 is severe degree of obstructive sleep apnea. So also in respiratory event, we see the oxygen saturation. So we also see the lowest oxygen saturation, and for what time this lowest oxygen saturation was there. We can have like what time the patient had more than 95% saturation, what time patient had 90 to 95%, what time patient had 85 to 90%, and what time patient had 80 to 85%, and how much time patient had less than 80% of the saturation. So this will show us the uh, urgency of treatment that patient require. So we go to another side, another alphabet of Sare Gamma. First, we'll consider MA, that is limb movement. So this investigation we are doing for the symptom patient is having excessive daytime sleepiness. So excessive daytime sleepiness patient is having because of not able to sleep in night, that is frequent arousal. So this frequent arousal can be either because of apnea, hypoapnea or RERA. But then suppose patient has apnea hypoapnea index or respiratory disturbance index very less 2 or 3, but then patient has periodic limb movement index 50. So we can say that frequent arousal in night time is because of periodic leg movement, not because of apnea or hypoapnea. And more than 15 per hour is abnormal in adult, and more than 5 periodic lip movement is abnormal in children. Per hour is abnormal in children. And sometimes this periodic leg movement in night is associated with restless leg syndrome, maybe at least in 30% of the patient. But restless leg syndrome is associated with periodic leg movement disorder in night almost 70% of the patients. Also, this is most probably is a systemic disorder which will involve a physician and neurophysician for evaluation, because it is due to affection of dopaminergic system and brain ion metabolism, and it need further evaluation like thyroid function test, vitamin B12, folate level, blood urea nitrogen, creatinine, other. So we have to also see sleep. We have to also see sleep periodic limb movement disorder. And next alphabet in Sare Gamma is, we'll consider that G is sleep fragmentation. So daytime sleepiness is because of arousal, and arousal can be because of apnea, hypoapnea, RERA, and then we saw it can be because of even periodic limb movement. But then, if neither had occurred and patient had arousal, it's called as spontaneous arousal. So we will have a column of arousals, and every arousal will be given a reason. So, how many arousals patient had and what were the causes? And if there is no cause, it is labeled as spontaneous arousal. So, spontaneous arousal can be because of hypervigilant stage and sleeping in strange place, because of pain, fibromyalgia, chronic back pain, and there is also spontaneous arousal index and total arousal index. So it can be also because of anxiety, depression. So maybe we have to evaluate, involve our psychiatrist in this patient, and try to find out what is the reason of patient's arousal, and that's why patient is having excessive daytime sleepiness. So the last thing which is also important is cardiac ECG, and it shows any pathogenic arrhythmias or other cardiac event. So to summarize, and one more thing I just want to let you know, the lab based study is type 1, type level 1 study is lab based study, which is gold standard. But then home based sleep studies also can be done. It is convenient, inexpensive, but the denominator used in home based study is most of the time total recorded time, not total sleep time. So it will have everything less. Apnea, hypoapnea will be, it will underestimate. And in lab based study, the problem what can occur is patient will not be able to sleep, maybe because of first night effect, and that is the problem. So this is the mnemonic which I have made to summarize my talk. Like, at these things we have to see, we have to make write on a paper, and we have to see all these things in sleep study. The mnemonic is atra lao. So A is apnea hypopnea index, to know the severity of obstructive sleep apnea. Total sleep time. See, this is important. If patient has done a level 1 study in lab and patient didn't sleep at all, patient slept for 1 hour, and if we do not notice that and we give our treatment on the basis of that, it may not be prudent. So maybe we have to repeat the test. And so third thing we have to see is REM latency, how much time it took patient to fall into first REM, and REM percentage, because as we know, if REM percentage is very less, means the study has underestimated the disease. Then we have to see apnea hypopnea index in supine and non-supine position. If patient has very less apnea hypopnea index in non-supine position, that gives a therapeutic value of advising patient to lie in lateral position or non-supine position, and he may not require any treatment at all. Then next is thing we have to see is limb movement index. So if patient has everything normal and increased limb movement index more than 15 in adult and more than 5 in children, he will require workup other than obstructive sleep apnea, metabolic workup, to know if he has other underlying illness. And if his even limb movement index is normal and arousal index is more, and there are most of the arousals are spontaneous arousal, then he'll need another kind of evaluation, maybe involving a psychiatric, or if the patient has chronic back pain, or he is anxious or hypervigilant, he has some depression or something else. And then we have to see his oxygen desaturation index, that like how, what was the lowest oxygen desaturation, and how much was the desaturation less than 80% time, how much time patient was in less than 80% desaturation time. And last we have to see his ECG. ECG will show us any urgent STT wave elevation or any pathogenic arrhythmias. And oxygen desaturation or lowest oxygen desaturation shows us urgency of treatment. Thank you very much for your patient listening. Thank you. So